Yes, ma'am.
Okay, so we can start now.
Yes, thank you. Good evening, everyone. A very warm welcome to all who have joined us for this session of ACP Case Files India Chapter. First of all, I would like to thank Dr. Anuj Maheshwari sir and Dr. Amit Gupta sir for giving me an opportunity to be here on this esteemed platform. Being the first session of the year 2023, we hope we have more and more thoughtful, interesting sessions in this year as well, which will help our early career physicians build up their knowledge and help us through our mind tickling cases in our daily clinical practice. So today we have two eminent speakers bubbling with knowledge to clear our concepts. For the first session, we have with us Dr. Manish Chande sir. Please, can you put this CV of Dr. Manish?
Dr. Amandeep, just before that, we will request our governor to say a few words about the ACP India case
sure.
file, and then we will proceed with the presentation. So, and as you all know,
you can finish your whatever you want to speak.
Hello.
Let her finish whatever she was speaking.
Yes, sir. Okay. Right.
Yes.
Yes.
Okay. Thank you, sir. So we have two eminent speakers bubbling with knowledge to clear concepts today. So before we start the session, Dr. Anuj Maheshwari, sir, please let us through this session.
Thank you everyone. Greetings from American College of Physicians India Chapter. I think in this year we are meeting for the first time. So this is the first ECP case file for the American College of Physicians India Chapter. And I hope that this new series of the ECP case file will definitely resolve your all queries and resolve your all problems which you are coming across in your day-to-day practice. So I believe today's session is coming up with a new insight regarding the case which is being discussed today is thyrotoxic periodic paralysis, and that too of the iatrogenic case which must have happened and being presented by Dr. Manish from who is the professor of internal medicine. Apart from that, there is the most important thing, and it has been also desired in our ACP town hall meeting by many of the clinicians that they want that medico-legal issues to be addressed. And for that purpose, Dr. Akhilesh Pathak from the AIMS Bathinda is joining us to clear up the issues related to the medico-legal issues in day-to-day practice. So would be very happy and would be very keen to see these two presentations. So over to Amandeep Kaur for the further proceeding. Now you can take the thread for the program.
Thank you, sir. Thank you so much, sir. So for the first session, we have with us Dr. Manish Chande. Sir is Professor of Medicine at Shri Guru Ramdas Institute of Medical Sciences and Research, Amritsar. Sir has a vast experience of 16 years and has presented papers and posters in various conferences and has chaired various scientific sessions. Sir has numerous publications in national and international journals and is a member of various scientific bodies. So today, sir will be presenting on iatrogenic hypokalemic periodic paralysis. Basically, this is a very rare neuromuscular disorder with an approximate incidence of 2% in patients with thyrotoxicosis, characterized by sudden onset of hypokalemia and muscle paralysis. So without wasting any further time, let us proceed to the case. Sir, please, you can start with your presentation. Thank you, sir.
Thank you, madam. Can you please share the slides, madam?
Yes. Can the team please share the slides of sir? I have already sent them.
Next slide, please. First of all, I like to thank the team ACP as well as Dr. Preeti and Dr. Aman for providing this opportunity to present a very informative case for the resident and all the clinicians. And now I would like to start with the topic. And this topic is very important, especially for the resident, because most of the time, periodic paralysis, when patient comes to us in emergency department, most of the time it's misdiagnosed as a case of Guillain-Barré syndrome, because this is one of the most closed, most this is the closest differential in hypokalemic periodic paralysis. So hypokalemic periodic paralysis is an actually autosomal dominant disorder, and it's characterized by episodic weakness of the skeletal muscles and affecting the proximal muscle more than the distal muscles. And it's more common in males with onset in adolescence and almost always before 25 years of age. This differentiation is much more important, and it should not be taken as a consensus that every patient who comes to with us with the periodic paralysis after 25 years of age will not be a hypokalemic periodic paralysis. This age differentiation just means that the onset of the disease is before 25 years of age, because once the patient have onset before 25 years of age, then the recurrence can occur even thereafter. So if a patient does not have, patient's first episode is after 25 years age, then we need to think some other alternative diagnosis or some acquired cause of periodic paralysis. And secondly, it involves the skeletal muscle, but rarely ocular and bulbar muscles. And similarly, respiratory muscles are usually spared, but when involved, it can prove fatal. Next slide, please. So this muscle weakness is characteristically episodic, and with low serum potassium levels during an attack and normal serum potassium levels in between the episode. So episode of muscle weakness, they are precipitated by rest following exertion or heavy exercise. This is more important because episode of periodic paralysis does not occur during exercise. It's only when the patient takes suitable rest after an heavy exertion, patient present with the weakness of all four limbs. And this is also more important because sometimes physical activity actually causes resolution of the episode. High carbohydrate diet that precipitate episode of muscle weakness, and similarly high sodium diet that also precipitate a similar event. Next slide, please. So, since hypokalemic periodic paralysis is an autosomal dominant condition, there are many other causes which actually present similarly as with the familial hypokalemic periodic paralysis, what we call as acquired or secondary causes of hypokalemic periodic paralysis. And one of the most common causes, thyrotoxic periodic paralysis. And it's also more common in Asian males. And but in female, it's even much rare, with the incidence in various Asian communities in the range of only 0.04 to 0.17%. Next slide, please. So the case which we are now going to discuss today is of a 32-year-old young female who presented to us in emergency department with the sudden onset of flaccid muscle weakness. So when we got the history, it revealed that she was well in the last evening when she did excessive workout in the gym. And when she woke up in the next morning, she was unable to get up from the bed just due to the weakness of all four limbs. So all residents who are listening, all students and all the budding practitioners, they must learn that this is the characteristic history of a patient of periodic paralysis, may it be thyrotoxic periodic paralysis, may it be hypokalemic periodic paralysis. Typically, the patient comes up with that he had a party last night or excessive workout in the last night, or had taken binge of alcohol in the last night, and then when he or she wake up in the morning, he or she felt the total weakness of all the four limbs. And similar was the case which we are discussing. She had a similar episode of weakness 2 weeks earlier, though less severe, and recovered spontaneously within 3 to 4 hours. And there was no relevant family history in this case. Next slide, please. So patient history revealed that she was overweight and was regularly visiting diet clinics for weight loss program, and was also following a gym instructor for the weight loss. And Past medical records showed that she had undergone a series of lab evaluation in the last 3 to 6 months, which were all within normal limits, including her blood sugar, her glycemic control and thyroid functions, serum electrolyte, renal function, liver function, all were within normal limits. And none of the old investigation recorded gave us any lead into the diagnosis of the acute onset of the weakness. Next slide, please. So in the neurological examination, we found that as usual with all the periodic paralysis, it was the lower limb which was more affected, which showed grade 1 power, and upper limb showed grade 2 power in both sides. Tone was decreased in all 4 limbs, and no involvement of bulbar muscle or ocular muscle was seen. Higher mental function as well as cranial nerves, they were normal, as well as speech was normal. No sensory deficit was elicited on examination. Plantars were bilateral flexor and deep tendon reflexes, they were diminished in both upper as well as lower limbs. Bladder bowels were uninvolved, and finding in rest of the organ system were unremarkable. Next slide, please. So this was examination, heart, lung, as well as abdomen examination. They were all normal. Old reports, old medical record showed almost reports, including LFTs, RFTs, electrolytes, thyroid function tests, they all were within normal limits. And on CNS examination, we find that bilateral upper and lower limb were weak, though the weakness was more seen in lower limbs. No fasciculations was evident in any muscle, and deep tendon reflexes were diminished, plantar flexor, gait as well as cerebellar testing was not elicited as due to the weakness, and similarly normal sensation were present throughout the body, and the patient was having BM of 29, she was afebrile, there were no goiter, no exophthalmos, and no skin changes of thyrotoxicosis, hypothyroidism was seen in this case. Next slide, please. So this was the lab evaluation. In the lab evaluation, find that patient was having significant hypokalemia and slight elevation of serum CPK and AC were present, and ECG was showing just sinus tachycardia with normal blood pressure. Next slide, please. So with this much clinical history and lab evaluation, a provisional diagnosis of hypokalemic periodic paralysis was made, and we started the patient with the potassium replacement, as usual it would do. But there was a catch in this case. The catch was that she was a young lady of 32-year-old, and the first episode of periodic paralysis, which hypokalemic periodic paralysis that occurred at this age, which is not usual. So we started thinking about some other causes of hypokalemic or periodic paralysis at this age, and one of the commonest causes thyrotoxic periodic paralysis. So thyrotoxic, keeping in view the thyrotoxic periodic paralysis, thyroid profile was also ordered, though except for the tachycardia, no other clinical feature of thyrotoxicosis were present. Next slide, please. So for the resident, they should learn that these are few of the causes of hypokalemic periodic paralysis. So there are two causes, though two main mechanisms by which patient can have significant hypokalemia and periodic paralysis. And one is the transcellular potassium experience influx of potassium while influx of potassium from the. Secondly, it is the increased sodium potassium loss in the urine that can cause significant hypokalemia. The previous slide, can you please show the previous slides? Yes. So the mechanism of transcellular shift of potassium is mostly seen in familial hypokalemic periodic paralysis and thyrotoxic periodic paralysis, while potassium deficit because of increased potassium loss in the urine is normally seen in renal tubular acidosis type 1 and type 2. And for the resident, they should learn that this is the type 1 and type 2 renal tubular acidosis that is associated with the hypokalemia, while type 4 is associated with the hyperkalemia. Significantly, some hyperaldosteronism or some other endocrine abnormality that can also present with the hypokalemic periodic paralysis or significant hypokalemia because of increased potassium loss in the urine. Can you show the next slide, please? So these were the lab investigations. These were the result of the lab investigation. Apart from the hypokalemia, after we received the thyroid profile report, we found that the T4 is high and TSH is suppressed in that case. So the diagnosis of hypokalemic periodic paralysis, which we thought it might be familial or idiopathic, it has been shifted to the thyrotoxic periodic paralysis. Next slide, please. Now, there is again a catch in this case. There was again catch in this case. Because report of thyroid profile, which confirmed that patient is having thyrotoxic state, that the old report shows that she was euthyroid about 3 months earlier. And the signs of thyroiditis, they were also lacking, though there was no tenderness in the thyroid palpation, there was no thyroid evidence of thyroiditis on ultrasound of thyroid. So inquiries were detected against any exogenous agent, including herbal medicine taken by the patient in her quest of losing weight. So patient denied taking any such agent except for dietary changes and a single tablet recommended by a local gym instructor. So on deep probing, when we asked the patient or her attendant to bring that medicine, we found that she was taking a levothyroxine 100 microgram daily in empty stomach in a quest to lose weight, and she had lost weight in last 3-4 months. Next slide, please. So this is one of the case where we found that this thyrotoxic periodic paralysis is not natural. It is an idiopathic case of thyrotoxic periodic paralysis. In the literature, similar cases have also been reported, though not exactly like the cases which we are discussing here. But in the recent, in the older literature, it has been already shown that the inducing thyrotoxicosis in many patients can actually causes symptoms similar to that of thyrotoxic periodic paralysis. So the management of thyrotoxic periodic paralysis is somewhat different to the hypokalemic periodic paralysis, which is idiopathic, or the hypokalemic periodic paralysis, which is because the increased potassium loss in the urine, as we see in patients of type 1 or type 2 renal tubular acidosis. Because the main mechanism in thyrotoxic periodic paralysis and familial periodic paralysis is the increased transcellular shift of the potassium from extracellular to the intracellular spaces. So while the mechanism of hypokalemia in those patients of type 1 or type 2 renal tubular acidosis or hyperaldosteronism is increased potassium loss in the urine. That means that when we manage the patient of thyrotoxic periodic paralysis appropriately, there is always a risk of rebound hyperkalemia if we replace the potassium excessively. So after 24 hours, the potassium supplementation was discontinued as thyrotoxic was confirmed, and patient was started on the propranolol 20 milligram thrice daily, which is the standard treatment for such patients. So patient started improving within 6 hours with corresponding improvement in serum potassium level, and patient's power was normal after 24 hours starting the treatment. So patient was kept under observation for the next 48 hours with strict monitoring of serum potassium level. The strict monitoring of serum potassium level is more important for the two aspects. One is that significant hypokalemia can induce some cardiopulmonary problems, including malignant ventricular arrhythmias. Secondly, in such cases, when we give beta blockers, the transcellular shift is reversed and patient can present to the rebound hyperkalemia. So to managing both these conditions is of paramount importance, and monitoring the serum potassium level is especially that important in such cases. Next slide, please. Can we move to next slide, please? So this was simply a case of thyrotoxic periodic paralysis. Why this case was unique? This case was unique because one is thyrotoxic periodic paralysis, not very common in females. Secondly, this was not the natural thyrotoxic state this patient presented with. This was iatrogenic case of thyrotoxic periodic paralysis, though not many cases have been reported in the recent past in the literature, but it has been shown that inducing hyperthyroidism by IV levothyroxine can cause thyrotoxic periodic paralysis in many societies or many subset of patients. So patient was discharged and was educated about harms of over-the-counter substance abuse, and also given strict instructions to avoid thyroxine abuse or any other miracle drugs recommended by non-physicians to lose weight. So patient was discontinued of propranolol after 3 months when the patient's thyroid function test showed normal reports. And on the follow-up till the last reported outpatient visit, she was symptom-free and achieved euthyroid status and reported no paralytic episode. So this was in a nutshell about this case. Next slide, please. Next slide, please. So for the resident, they should know, madam, please, previous slides. Previous slide, please. Can you show the previous slide? Next slide. Next slide. Yes. Thyrotoxic periodic paralysis is a rare but potentially lethal complication of hyperthyroidism, and it's characterized by episode of transient flaccid muscle weakness, predominantly of the proximal muscle, accompanied by hypokalemia secondary to massive intracellular shift of potassium due to thyrotoxicosis. And this is the main mechanism of hypokalemia and thyrotoxic periodic paralysis, and affects male of Asian descent. This is episodic. And what's more important to remember is that episode of muscle weakness in thyrotoxic periodic paralysis, they are induced only when the patient is in thyrotoxic state, and they are never seen when patient is in euthyroid state. And effective management of hyperthyroidism that prevents the recurrence of paralytic episode. The mainstay of the management in such cases is to achieve the euthyroid state. Next slide, please. So clinical feature of thyrotoxic periodic paralysis is very similar to hypokalemic periodic paralysis, and all the manifestations, they are similar except few slight changes, that patient must be having hyperthyroidism with thyrotoxic periodic paralysis. And this hyperthyroidism may not be clinically evident because most of the time this the level of thyroid hormone is not related to the severity of the periodic paralysis, the severity of the episodic weakness. And secondly, the signs of hyperthyroidism in such cases, most of the time they are very subtle. And onset of the first episode of hypokalemic periodic paralysis almost always before 25 years of age. And if patient has first episode after 25 years of age, then you should need to think about some secondary causes of hypokalemic periodic paralysis. It's an autosomal dominant disorder via hypokalemic periodic paralysis, while thyrotoxic periodic paralysis is sporadic disease and the familial trait is rare. Please, next slide. So the closest differential is hypokalemic periodic paralysis, which is inherited disorder with normal thyroid level. Secondly, in those patients who are having hypokalemic periodic paralysis or thyrotoxic periodic paralysis, you should remember that the serum potassium level, they are low only during the paralytic episode, but the serum potassium level, they are normal in between the episodes. Please, next. So these are few of the differentials which every resident must know while managing a case of acute flaccid weakness. Thyrotoxic periodic paralysis and familial hypokalemic periodic paralysis, they are the episodic weakness. Most of the time, patient will give you history of prior similar episode, but not when the patient presents with the first episode. Secondly, duration of the muscle symptom, they are short and 30 minutes to 6 hours in thyrotoxic periodic paralysis, but maybe up to 24 to 40 hours in familial periodic paralysis. But in GBS, it is progressive over days to few weeks even. While the proximal myopathy, because of thyrotoxicosis, the weakness persists throughout the thyrotoxic state. And serum potassium level, they are low only in the thyrotoxic periodic paralysis and hypokalemic periodic paralysis. And these are associated with some genetic inheritance, while no genetic inheritance is observed in those patients of Guillain-Barré syndrome. Next slide, please. So the clinical presentation is typical what we just discussed. This is muscle weakness affecting the lower limb, more common as compared to the upper limb. Most of the time, patient present early in the morning or after the rest following the sternal exercise, and a high carbohydrate meal leaving the patient unable to move. Lower limb involved more commonly. Bulbar weakness is rare. Higher mental functions, they remain unaltered throughout the episode. Next slide, please. Next. So these are few of the triggers which can induce episode of weakness in those patients. Let me tell you the triggers of, madam, previous slides. Previous slide. The triggers responsible for causing episodic weakness or precipitating an episodic weakness, they are similar in hypokalemic periodic paralysis as well as the patient of thyrotoxic periodic paralysis. Madam, previous slide, please. And these are high carbohydrate diet, high salt diet, rest following an exertion. Madam, previous slide, please. These are the three most common precipitants of acute flaccid weakness in patient of thyrotoxic periodic paralysis, as well as the patient of hypokalemic periodic paralysis. So when to suspect? Always suspect a patient who comes to you with the acute flaccid weakness. When you suspect a patient with Guillain-Barré syndrome, always keep periodic paralysis in your differentials. Just a serum potassium level, which is a very simple test, you can make a diagnosis of hypokalemic periodic paralysis in such cases. Detailed clinical history, thorough clinical examination, feature of thyrotoxicosis may be absent in or very subtle in most of the patient, and clinician must have a high index of suspicion in diagnosing such cases. The frequency and severity of the episode does not correlate with the severity of the thyrotoxic state, and the restoration of the euthyroid state actually abolishes the further attacks. Spot urine tests for electrolyte and potassium excretion can be very useful to differentiate thyrotoxic periodic paralysis, hypokalemic periodic paralysis from the periodic paralysis of hypokalemia because of type 1, type 2 renal tubular acidosis, because of excessive potassium loss in the urine. Because in hypokalemic periodic paralysis and thyrotoxic periodic paralysis, potassium excretion will be low or normal, while in those cases of type 1 or type 2 renal tubular acidosis, potassium excretion will be high. There will be normal acid waste status and low urinary potassium level. They are characteristic of hypokalemia in thyrotoxic periodic paralysis. It's also important to appreciate that serum potassium levels may be normal in between attacks. Next, please. Please, next slide. So patient of thyroid, madam, previous slide, please. Just that's very important. Please, previous slides. Previous slide, please. So patient have been found to have significant, what is the pathology? Pathology, madam, next slide, please. Pathology is the increased sodium potassium ATPase pump activity as well as number in thyrotoxic periodic paralysis that actually causes massive intercellular shift of the potassium during thyrotoxic state as well as during the stress or increased catecholamine release. So thyroxine, insulin, and catecholamine that increase the activity of these pumps, leading to intracellular shift of the potassium and resulting hypokalemia. This is well demonstrated as restoration of the normal potassium level terminates the acute attack. A rebound hyperkalemia can occur as the acute episode resolves due to extracellular shift of the potassium. So potassium supplementation should be closely monitored and should not be too vigorous to avoid rebound hyperkalemia. Propranolol is a non-selective beta blocker and it promotes early resolution of the weakness and hypokalemia without increasing the risk of rebound hyperkalemia. Because propranolol actually prevents the recurrence of episode by inhibiting the activity of sodium potassium ATPase. So it should be used in preference to potassium supplementation in patient at risk of cardiopulmonary arrest. Next slide. So this is to summarize the whole talk. That patient with thyrotoxic periodic paralysis, the predominant prerequisite is patient must be in hyperthyroidism. It's more common in male of 20 to 40 years of age of Asian descent. There are many genetic mutations that had been postulated to cause this disease, but none has been shown to be accurately closely associated with any of these. These are the triggers: night or early morning, and high carbohydrate diet, alcohol, heavy exertion, infections, tests, beta 2 bronchodilator. They all can act as a trigger. And the clinical manifestation, they are typical to the hypokalemic periodic paralysis with acute onset of weakness, with palpitation, weight loss, tremor, heat intolerance of hyperthyroidism. Then there might be paralysis without sensory abnormality. Then ECG finding must be typical of hypokalemia as U wave, sinus tachycardia, PR prolongation, ventricular arrhythmias. And lab findings apart from the suppressed TSH are hypokalemia, hypomagnesemia, and hypophosphatemia. Though hypercalciuria and hypophosphaturia can also be seen in such patient, along with the low urinary potassium excretion. Mind you, if such patient presents you, this is a very simple test of checking the urinary potassium excretion, which can differentiate thyrotoxic periodic paralysis and hypokalemic periodic paralysis from the other causes of periodic paralysis or significant hypokalemia, like renal tubular acidosis type 1 and type 2, which we have seen recently, few cases of hypokalemic periodic paralysis, where urinary excretion of potassium was high, and ultimately they were found to be having type 1 renal tubular acidosis secondary to Sjogren's syndrome, which we have seen in the recent past two such cases. Thank you. This was all about the this topic and the case. I hope resident must have got a significant information, and I must have contributed to add to their knowledge.
Thank you, sir. Thank you so much for such an enlightening session. We will now be taking any questions. I think there are no questions presently in the chat box. Any questions by the audience, please?
I would like to ask a question.
Yes, ma'am, please.
Firstly, I would like to congratulate you, sir, for such an informative and interesting case presentation. So
Thank you,
you have
madam.
always been a most respected teacher and always encouraging us to think differently.
That's so nice of you, madam.
So I wanted to ask, how do we replace this potassium in such patients when saline or dextrose infusions are known to precipitate the paralytic attacks?
I think this is a very important question, because many times what residents do when we ask them to replace the potassium, especially when we need to give IV potassium, it's a very common question, because recently we discussed that high salt diet or a sodium replacement or a sodium saline infusion can actually precipitate such attacks. Similarly, glucose load as well as dextrose infusion can also further precipitate such attack. And I can tell you the most suitable vehicle for replacing IV potassium in such cases is the mannitol. And definitely this has been mentioned everywhere in the literature in the recent past, though it's not commonly read in the recent books. But I can tell you that mannitol is the most suitable solvent or most suitable vehicle for replacing IV potassium in such cases.
Okay, so I think we have another question in the chat box. It says, what type of cases are included?
What type of cases are?
What type of cases are included?
Included where?
This question is not clear.
I can tell you the differentials of such cases. One thing is when when acute flaccid patient present with acute flaccid muscle weakness, first thing is you have to differentiate whether it is Guillain-Barré syndrome or some neuropathy or some myelopathy, or it is a just neuromuscular junction involvement. So hypokalemic periodic paralysis is one of the cause, though it's not the sole cause of acute flaccid muscle weakness. There are multiple causes of acute flaccid muscle weakness, but when you make a diagnosis of hypokalemic periodic paralysis, there are multiple causes of hypokalemia in such cases which can cause acute muscle weakness. One of them is the flaccid muscle weakness or hypokalemic periodic paralysis, which is the familial one. Second is thyrotoxic periodic paralysis. Then hypokalemia is significant because of some renal tubular acidosis, because of some barium poisoning, insulin infusion, hypodiuretic abuse. There are multiple causes which can cause hypokalemia and ultimately acute flaccid muscle weakness. But the typical history will help you to differentiate this hypokalemic periodic paralysis from the other causes of muscle weakness. And definitely investigation will play a major role in differentiating this condition. Like in patient of Guillain-Barré syndrome, The typical NCS findings are very typical of GBS, which actually show acute inflammatory demyelinating polyneuropathy. While in hypokalemic periodic paralysis, the muscle action potential will show reduced amplitude, while EMG will show the electrical silence. While the EMG will be not those patient of Guillain-Barré syndrome.
Thank you, sir. Thank you so much.
Thank you, madam, for giving me this opportunity to present such a case for the resident and all the faculty as well as the budding physicians.
Thank you, sir. Thank you so much. So, periodic paralysis, being a life-threatening medical emergency, needs urgent evaluation. So, we all must be well acquainted with the causes as well as the underlying treatment for the same, as well as the underlying pathogenic and physiological mechanisms. Thank you so much, sir, for enlightening us on this session. Thank you so much. So, now we will be beginning with our second session. For our second session, we have Dr. Professor Akhilesh Pathak. Sir is professor and head of the Department of Forensic Medicine and Toxicology at AIIMS Bathinda. Sir was awarded the MD Forensic Medicine by SMS Jaipur in 2004 and awarded the postgraduate diploma in Health and Law by Academy of Hospital Administration, Noida. Sir has also done training courses on human identification from University of Scotland, UK, and training courses on forensic physiology from the Open University, Walton Hall, UK. Sir has 21 years experience of teaching and has conducted around 3,000 autopsies. Sir was awarded the Eminent Scientist Award in Forensic Medicine in conference supported by TST and Government of India and has also been awarded the membership of NAMS. Sir has delivered numerous lectures as guest speaker in various scientific conferences, CMEs, and webinars, and has published 58 research papers in various national and international journals. Sir is also a member of various scientific bodies in India and abroad. Sir is an author of the textbook of forensic medicine, as well as an editor and editorial board member and peer reviewer in 12 journals of specialty from India and abroad. Sir has also guided MD and PhD students in the subject of forensic medicine and toxicology and has evaluated around 25 theses of various universities in Rajasthan, Gujarat, Maharashtra, and Himachal Pradesh. So today, Sir will be presenting and enlightening us on the topic medico-legal pitfalls in the daily practice. Now, this topic, as we all know, is the need of the hour, seeing the rising number of the MLC cases. So, I would now request Sir to kindly start with your presentation. Sir, please.
Thank you, Dr. Aman. Am I audible?
Hanchi, sir, you're audible, sir. Thank you, sir.
Okay, so we'll try to share my screen.
So we can share your screen if you want, sir.
Okay, is it visible?
Hanchi, sir, your screen is visible, sir.
Okay, and okay, is it moving?
Sir, not yet. Sir, you can. It's moving now, sir. It's moving.
Okay, fine. Okay,
Hanchi,
fine. Thank you, Dr. Aman.
Thank you.
Thank you, Dr. Anuj Maheshwari, Dr. Amit Gupta, Dr. Preeti Dhot, and Dr. Aman, and the whole team API for giving me this opportunity to share the experience and the knowledge regarding the medical legal work. And this is one of the important topic that we should be aware that what are the different pitfalls in our daily practice. So what are the various, whenever we are dealing with the cases, as you guys are the expert of the medicine and you are dealing with so many cases, so it is easy for you to treat and handle all kind of the cases. But whenever a medical legal case comes to you, so it is a routine practice that if you are sitting in OPD, you are sitting in casualty department or working in Indo, then you have gone through so many medical legal cases. So what are the various pitfalls or common mistakes we do whenever we are dealing with such kind of the medical legal cases. I would like to highlight some of the important things in this case. So this is the overview of my presentation. We may mistake in identifying first, that is the most important one. And then if we are able to identify the medical legal case, then we may mistake in performing the legal duties which are associated with all these cases. We commonly do mistake in taking the consent. We may mistake by imposing ourselves as a specialist or super specialist without having a proper degree. Then we may mistake also in taking the insurance, that is the indemnity insurance. We also may mistake in documentation and in cases of the received debt. So I am having some of the examples here, and you may agree or disagree. You may write down yes or no in the chat box that one person was going on the bike and met with an accident with a car. Is it a case of MLC? You may write down yes or no in the chat box. So in another scenario, one person was going on the bike and this time he got injured due to slipping of the bike. So is it a case of MLC? Yes or no? So some of you may agree and some of you may disagree with that. In another scenario, a person was going on a road and hit by the cow. So he got injured with that. So is it a case of MLC? Or would you like to sue that cow? So in another scenario, the person was going and fell down in the manhole. And is it a case of MLC? Slipping in bathroom and got injured, fracture neck of femur. In old cases, it is very common. So is it a case of MLC? A person who is used to and regularly climbing on the trees for his business purpose, but one day he fell down and got injured and came to you in the casualty department. Is it a case of MLC? So these are the various circumstances, scenarios. Here you can see some of the snake bite and honeybee stinging. All these cases are some of the gray areas where a person may agree or may disagree that it is a case of MLC. So actually, what is that? What is MLC? Is it a MLC or not? So what is actually a medical legal case? A medical legal case is a case where after examining the patient, we as a doctor are thinking that some of the investigation by the law enforcement agencies should be done in that particular case to fix the responsibility of a particular person. So in easy language, if I will try to explain, then anything which is unnatural is known as MLC. Suppose I used to, for taking the classes and regularly taking the classes in my institute, one day I went to take the class and suddenly I touched the microphone or I got an electric shock. So visiting regularly for the class is a natural thing for me, but getting an electric shock for a particular day is not natural. It is something unnatural. In similar scenario, the students are sitting in the class and they are taking the lecture. So that is a common thing. They are used to for that. They are going regularly everywhere. They are taking the class. But one day, a tile from the ceiling tile fell down over the head of a student. Is it a natural? So it is not natural. This is something unnatural. So anything which is not natural or unnatural, that should be considered as a medical legal case in a simple language. So here, the responsibility of a person that should be decided. Suppose we took a case of that cow head injury. So who is the owner of that cow? Why the cow is moving here and there, abandoning over the road? How it came over the road? So that owner, that he may be sued for that, for the punishment regarding that. So that kind of the cases are medical legal. So we should not mistake in identifying these cases. When we are identifying these cases, then definitely the next responsibility is the registration of that MLC case. So when we are registering a case as a MLC, we should have a medical legal register. We have to mention the details of the patient, name, age, sex, whatever the history is there, time and incidence, and the other brief details about that medical legal case. After that, we should allot a medical legal number or MLC case number that should be clearly written, and it should be visible to all other person who are coming in contact with the same documents. They should be able to identify that yes, this case belongs to the MLC or medical legal case. So next, our legal duty whenever we are labeling a case is MLC, then our most important duty is to inform the police. So in all cases of the medical legal case, the police should be informed, because police is the investigating agency in all these cases, and there should be investigation regarding to fix the responsibility of a particular person in that case, that who is responsible for that kind of unnatural thing. So police information should be given in all cases, and it is compulsory. If we are not providing the police information, trying to hide that, there may be imprisonment of 6 months in that. But again, that is a big question, how to inform the police. So that may be another problem to us. So we can inform the police guys by in the two form, either through the phone or telephonic information we can give, or in written information we can give the information to the police. So when you it's easy to call to the police, but the most important thing that you have to document that thing, that I have informed the head constable Sarla at this time and on the date, on this particular date. So that information that I have disseminated the information to the police at this time, at this particular date, that should be mentioned in your document. So documentation is very important in all cases of the medical legal cases. In another form, in written police information, that also can be given. Here I have prepared this template for our institute, where such kind of the templates you can use. You can write down the alleged history of the incidents with the details of the patient, then who brought this patient, and what is the scenario. So original copy will be sent to the police, and the office copy will be there with you in the record. So in this form also we can disseminate the information to the police. Another mistake in referring, so whenever we are referring such kind of the MLC cases, it is my humble request that please clearly mention that whether MLC has been done in that particular cases or not. So suppose in AIMS we are working, so we are receiving so many cases from the periphery. The patient is transferred to the hospital, he is having the hospital record, but there is nothing is mentioned that MLC has been prepared or not. So MLC done should be mentioned, means the all formalities related with the medical legal case has been done in that particular case. So means the medical legal report has been prepared regarding that. So whenever we are receiving the case in our AIMS, we are not able to know whether the medical legal report has been prepared in the periphery or not. And it is the duty, remember, it is the duty of the first attending doctor to prepare the medical legal report, and eligibility to prepare this report is just a doctor who can prescribe the medicine can prepare the medical legal report, means a registered medical practitioner. A medical practitioner who has got registration, he can prepare the medical legal report. But again, this is a problem. Nobody wants to do that work. So it is my advice that you can take the help of a government doctor, or you can hire some of the forensic experts for preparation and handling all the other medical legal work related to your patients. So if you are working in a private hospitals, hire a forensic person to prepare the MLC report of this case and the all cases, as well as he will take care all the medical legal formalities related with that case. So suppose if there is a death is occurring, lama is there occurring, or whatever, if any sample he has to preserve, or preparation of the medical legal report, even up to the autopsy level, he will take care of all these things. The charges of that preparation of that medical legal report, that can be added in the bill of the patient. So I have seen this kind of the practice in some of the state, especially in Gujarat when I was working. The most of the private hospitals, they were having one forensic person to do the all MLC works related with case. So the information regarding the MLC cases, whatever admitted to the hospital, it was sent to the concerning attached forensic expert. He visit to the hospital and prepare the MLC report, and will take care all the formalities regarding the MLC. So that is a easy idea to take care of this such kind of the things. So duty to preserve the various samples. So whenever we are dealing such kind of the cases, there may be some of the issues where we have to preserve the sample for the investigation, which are compulsory as per the law. I'm not going in details regarding the laws. What are the medical legal samples that should be preserved? It should be sealed, and it should be handed over to the police for further analysis after taking a receipt of it. So definitely, when being a physician, we want to focus on our clinical practice. So it's better you can take the help of some other government doctors who can prepare this MLR report and can do the work for you. So sample to be preserved, like in poisoning cases, whenever you guys are handling the cases of the poisoning, it is the compulsory duty that blood sample, urine sample, and lavage sample, first sample of the gastric lavage, that should be preserved, it should be sealed, it should be handed over to the police for the further analysis. Whenever you are dealing with the sexual assault cases, then as per the Ministry of Health, there are lots of these samples to be preserved. In that, I'm not going in detail. It is related with the gynae department. Sometimes the surgeons, they are doing the surgeries and they are getting some kind of the bullet or any foreign body, any weapon or any gauze piece left inside the abdominal cavity. So if they are removing such kind of the things or any foreign body is recovered, then that should be preserved for the further investigation. In criminal cases of the abortion, fetus should be preserved. So these kinds of the mistakes we should avoid. Another mistake, that is the imposing himself or herself as a specialist or super specialist without having a recognized degree. So suppose I am appointed as an assistant professor in ENT department, and imposing myself as a head and neck surgeon. So this is another problem. So one person is a MD medicine, and he has done some of the training course of the rheumatology, and now imposing herself or himself as a rheumatologist. So as we all know that there is a DM in that particular field, and that degree is recognized. But whenever you are writing something, there is nothing in practice of rheumatology. There is nothing wrong in practice of diabetology or endocrinology. But whenever such kind of the cases went to the court, then court may ask you a degree regarding that, because they know that there is a endocrinologist is there, a rheumatologist is there, and a gastroenterologist is there with a recognized degree. So they can ask you that, Doctor, please submit your degree and whether it is recognized or not. So that is again a common mistake we do here. There are lots of the court cases are available on the Google, you can see. So one case in which the Dr. Vijay Suren, he was the general practitioner in Jaipur. He was running a maternity hospital, and he was punished by the court for the delivering of his stillbirth, and the reason was there was the cord around the neck. So because he was not having a proper degree for running a maternity hospital, so the doctor was punished for that. And there were also other important things were also there in that case. Another mistake we commonly do, that leaving patient to untrained junior staff. So it is commonly seen that we are having the hospital, we admit the patient, different type of the patient in our hospital. But whenever the patient requires your help, or if there is any emergencies there, then patient may require immediate attention by the doctor. And in that circumstances, if we are not available, the doctor is not available in the hospital, he has gone for enjoying the movie, or he may left the town for some work, and left these patient to a junior staff. So all these patients are admitted under you. They have given consent for the treatment by you, but not for by your understaff. So without their consent, we cannot hand over our patient to another doctor. So this is another problem. So a different type of the cases has been done in the court, and the unfortunately the punishment was awarded in such of the cases. So a patient was admitted to the hospital and doctor left the town, and patient was with the junior staff, and if there is any problem was there. In the same case, in Dr. Vijay Suren case, in which the baby was delivered stillbirth, there was a cord around the neck, and the doctor was not present at that time in the town, and the junior doctor completed the delivery, and unfortunately it delivered a stillbirth. So cord around neck is a easy thing, and it can be diagnosed by a simple sonography just at the time of delivery, or if there is no descent of the fetus, is if there is a indication that fetus is not coming up or baby is not coming down, there it is a case of cesarean section. So it is an indication of cesarean section which was not taken care of in this case, and hence the court took it as a seriously. And in another cases which I have done so many autopsies regarding such of the allegations. In another case, the patient was admitted for the delivery. The doctor told the relative that it is a case of normal delivery, and there is no complication in this case. And when the relatives called repeatedly, doctor who was sleeping just above the hospital in his house. So home was just above the hospital, and the relatives were calling again and again, the patient is having problem, patient is having problem. Finally, the patient died because of some reason, and the autopsy was done with the allegation of the negligence over that doctor. So such kind of the cases, if we have admitted the patient, we should take care. If we are leaving the hospital, inform the patient, hand over that patient to a trained staff who will take care of that patient. Guys, another and most common mistake we all do, that is not taking the proper consent. That is another and big problem. We are not taking the consent from an adult who is capable of giving consent. A patient is coming, he is adult and well orientated, cooperative, he can give the consent. But we are taking the consent from the father, we are taking the consent from his wife. There is no need. When the patient can give the consent, you can take the consent from that patient. So that kind of mistake we commonly do, and doing more than for what you have taken the consent. Suppose you are going to do a diagnostic laparotomy and you are also doing the cholecystectomy. It may be because of some reason, but you have not taken the consent for the cholecystectomy. So in that kind of the cases also, if we are doing, then also the court will not consider such kind of the consent. Consent, if it is not taken in the language of the patient, as we all know, if the patient is understanding the Punjabi language, the consent should be taken in the Punjabi language. If we are taking that in Hindi, English, or anything, patient is not understanding it well, then it may cause problem in the court. No signature of the physician. So consent is basically, it is a contract between the patient and the doctor. So both parties should sign over the document, but it is usually observed we send to the nursing staff ki jao bhai consent le lo, or nursing staff us form pe sign karati, but there is no signature over that consent form by the doctor. And remember, there should always be a neutral witness from the both side. Means from the patient side, maybe a relative, maybe a parents, maybe wife or any son or daughter, and from the hospital side, a neutral witness in the form of nursing staff or any other hospital staff. So actually there must be a 4 signature over the consent form. Then name of the procedure, that is not mentioned. For what purpose you have taken the consent? So that should also be mentioned in this consent form. For what specific procedure you have taken the consent. If you are suspecting any kind of blood transfusion, please take a separate consent for that. A separate consent for anesthesia, that also should be taken. So remember, whatever the procedures you are going to do, and think accordingly, and mention is inform it clearly to the patient and take the consent properly. No witness in high risk consent. So high risk consent is slightly different from that one. So that should also be taken. Not inform the potential risk, not informing about the whatever the expenses are also there. So all these things These are the common mistakes we do whenever we are taking the consent. So these are the problems. And another mistake that is we commonly do, that not having the proper indemnity insurance. How many of us are having indemnity insurance? How many? So it is, think about that, if you are in a practice, if you are doing the practice of the medicine, you should have indemnity insurance. And in detail, if it requires a whole day to discuss over this indemnity insurance, I am not going in detail. So many of us are still not having, and especially the government doctor. Government doctor ko lagta hai ki we are the immune. We cannot be penalized by the court. So there is no need to take the consent. Even, I don't know, even our institute also, how many of the doctors are having the indemnity insurance regarding that. So, and some of the nursing staff, technicians, and whoever are involved in the team, they should also have the indemnity insurance, because I've seen the cases in where the whole team, even the technician, paramedical staff, nursing staff, they all were penalized by the court. So it is not there that the claim can be done only against the doctor. It can again be done against the nursing staff also. These are some of the advice whenever you are taking the indemnity insurance. Then at least take 2 or 3 policies of different range. Some will be of 5 lakhs, some will be of 10 lakhs, some will be of 50 lakhs, like this. Suppose if you are taking the one big policy, like 1 CR policy, so judge will see, whenever the case will come into the court, the judge will see that, okay, 1 CR policy he or she is having, so just he will find the 50 lakh rupees or 75 rupees, because you are already having the 1 CR policy. So in that way, so at least have 2 or 3 policies. Read carefully the terms and condition, क्योंकि कई बार क्या होता है कि that indemnity insurance policy is given for you to work in a particular hospital. Suppose you are working in a AIMS hospital, so there, when you will take the indemnity insurance, it will be given to you for work only in AIMS. But if you are working in a camp, which is organized by the camp in a nearby hospital or in a periphery, and if there is any mistake has been done, so whether this policy include that also or not. So that kind of the minute things that should be taken carefully, read it carefully. Is it covered outside the hospital also or not? And so many other things are also should be included in the indemnity insurance. I'm not going in detail. Again, this is another big challenge, that is the record keeping and documentation. So documentation should be very important. It is very important part of the medical legal work. Whenever the case will go for any allegation of the negligence, then the case file will be sent for the medical board, which will be found by the medical superintendent or by the institute to decide whether medical negligence is there or not. So if you have done the proper documentation, that will be better for you. And good documentation means good defense. Poor documentation means poor defense. So if you did not document it, you did not do it. अगर आपने किया है और अगर आपने डॉक्यूमेंट में नहीं मेंशन किया कि भाई मैंने पुलिस इंफॉर्मेशन दिया था, इतने बजे दिया था, इस तारीख को दिया था, इस हेड कांस्टेबल को दिया था, इस पुलिस स्टेशन में दिया था, अगर आपने डॉक्यूमेंट के अंदर नहीं लिखा है, मींस कि आपने नहीं दिया। क्यों? क्योंकि बाद में जब केस एनालाइज होगा, व्हेन द केस द होल फाइल विल बी एनालाइज्ड बाय द एक्सपर्ट्स, then only the documentation will save you. So remember, these are the things. Poor documentation means poor defense in court. No documentation means no defense in court. So this is one of the important case which I would like to discuss with you. Kunal Saha, wife, she died in Breach Candy Hospital. But before death, she was also admitted in AMRI Hospital in Mumbai only for 4 days. So initial for 4 days, she was admitted in AMRI Hospital, then shifted to the Breach Candy Hospital. And total 11 CR penalty was given by the court against the AMRI Hospital. Remember, so Breach Candy Hospital was not penalized because they were having the excellent documentation. So documentation saved them, but because the penalty was given by the court, so it shifted to the AMRI Hospital, who was having the very, very poor documentation in that case. So again, you can see, so we do a procedure and we are doing or writing normal. Suppose you are doing a laparotomy or you are doing a bronchoscopy, and after that doing a whole procedure, you are giving the anesthesia, what you are writing just it's normal. So court does not expect such kind of the reports. So it is my humble request. So whenever you are doing such kind of the procedure, please write in detail. Please write in detail that how you did it, what anesthesia was used, what was the nature of the entry, what was the mucosa lining, how it was looking. All things should be what was the fluid collection and all. So write in detail about the procedure and then write your opinion that nothing was found abnormal during this whole procedure. So if you are writing in detail, it will be easy to understand by the court, or you may convince in the court whenever it goes. So I've already told you that documentation should be perfect. And another big challenge is how long we should keep these records. So keeping these records is very important. Just for OPD records, it should be kept for the 5 years, for indoor, and for MLC records for the 10 years. So at least for the 10 years, for the indoor patient, for OPD patients, you can store the record for the 5 years. And whenever the record copy is asked by the relative or by any investigating agency, it should be given within 72 hours. So just do a Xerox of that and hand over it with your certification that it is certified from your side. Another mistake we do in receive dead cases, if you are receiving a patient who is dead or just or died just after arrival in your hospital, then remember, please do not give or please do not issue cause of death certificate in that case, because you are not able to diagnose that, you have not done your examination, not done any investigation over that. So you are not able to diagnose that how he died. So in that case, we cannot issue a certificate of cause of death and police information to be done that this patient came to me and death has happened because of this. So they will start their investigation accordingly. And you can send the body for the autopsy examination also. So now I would like to summarize this. Please identify the MLC, and some of the gray areas are there, like in sleeping in bathroom. You can avoid that as we are commonly doing practice, but actually it is a MLC. Like snake bite cases, in some of the institute, they do not register as a MLC, because how you will sue the case of, it is a rare possibility that someone has left the snake to bite you, or may having a tendency want to harm you with a snake bite. Inform the police in all MLC cases, preserve the evidential material, take proper consent, that is very, very important, and always do proper documentation. Please have indemnity insurance if you are not having that, and do not issue any cause of death certificate in received death cases. And one of the best thing, that have some forensic friends, lawyers who can guide you at whenever there is any problem comes. So guys, medical practice is like driving through an accident prone highway, and make sure that you are competent driver, means stay within your limits or what is your expertise is there. Your ignition is working fine, means you have taken the informed consent. The engine oil, fuel, all are good, means documentation and medical records, you are keeping it properly. GPS communication, so you have communicated all things patients at timely. So all these things, and brakes, know where to stop and what to avoid. So these are the few of the things. Happy and safe driving. Thank you.
Thank you so much, sir. Thank you for this enlightening session.
Thank you.
We'll be looking for any questions in the chat box. Presently, sir, there are no questions, but sir, I have an important question, like we're facing in our daily emergencies.
Yes.
What to do if the relatives request for not informing the police in case of MLC cases?
Yes, it is very important question, Dr. Aman, because whenever you are in practice, there will be so many different scenarios when their request will be there from the relative side that please do not make it MLC, डॉक्टर साहब इसमें पुलिस की क्या जरूरत है? But as we are bound to do, it is our legal duty to inform the police. So in all cases, we have to inform the police. Now it is over the police that what they will do with that case. They will file a case against that or not. It is their duty, but our duty we have to fulfill.
Thank you, sir. Thank you so much. Any other question, please?
I would like to ask a question.
Yes, ma'am.
First of all, thank you, sir, for such a wonderful session. Sir, I want to ask what to do if there is an allegation of negligence. In that situation, what can we do?
As I have already told you so many things, that whenever there is an allegation, first thing, anybody can allegate anyone. So there is no need to do any panic in that case. Just go through your file, complete it properly. You can take the help of any your forensic friend that how to complete the documentation. What is the allegation over you? Try to know that what exactly allegation is this. And just I want to share my experience with you that in last 20 years of my experience, I have received so many, I've done so many autopsies in cases of alleged negligence. And whenever there is a allegation of negligence is there, always the case will be transferred to a medical board. Again, that medical board will be of guys which are amongst us. Means they all are doctors. So they will definitely go through the case. They will try to find out whether there is any gross negligence has been done by that doctor or not. But in my last 20 years, I can say one thing to you that no doctor has been, I have not given any opinion that this doctor is negligent. Though there were so many cases in which the doctor was negligent, but I have never mentioned that I have always mentioned that this case there because there may be the complications. You see, if you are doing a cholecystectomy, patient is dying. You have done lots of the cholecystectomy, and in one case, if the patient is dying, so there may be the possibility of some complication. It is mentioned in the book that in 1,000 cases, in 5% cases, this complication will occur, that complication will occur, and probably that complication is mentioned in your documentation. So in that way it goes.
Okay, sir. Thank you so much, sir. Thank you, sir.
Thank you, Dr. Akhilesh. You have given a very elucid talk. And I
Thank
think
you, Dr. Amit.
It was really a pleasure to meet you during the UP Epicon in Noida.
Yes,
and
sir.
it
Yes,
is
sir.
really a pleasure to have you here again. And Dr. Manish also presented very well. Thank you, Dr. Manish, for your very good presentation. And Dr. Akhilesh, today you have told the ACP early career physicians that what should be done. I'm sure we will reach out again to you, and in that case, you should be telling us what are our strengths also. So
Yes,
what are
definitely.
our rights also? So many of the times we don't know what are our rights. So
Yes,
doctors, whenever there is any issue, so they get panicky, and because we are not knowing our rights and everything.
Yes. So
And
what options we are having in such cases or in
yes,
such scenario? Yes.
yes. So I think now we would like to have some of our forensic people as friends, as you have mentioned us. And
Yes, sir. Definitely. And next time
yes,
I will take this also that
yes,
how we can what options we are having.
yes. So ACP India case file definitely is very, very thankful to Dr. Manish Shande, Dr. Akhilesh
Thank you,
Pathak,
sir.
Dr.
Thank you, sir.
Amandeep for organizing it so well. And I am also very thankful to Dr. Preeti because of because she was the one who was coordinating with all of you and arranging slides, arranging presentation, deciding the topics, finalizing each and everything. So many, many congratulations to you,
Thank
Dr.
you,
Preeti.
sir. Thank you, sir.
And as you all know that we just returned from the Epicon. Only yesterday the Epicon finished, and to be back with the ACP case files and that too with two such very good presentations, it's really we are really happy with the ACP India case. So, over to you, Dr. Amandeep and Dr. Preeti, for the final remarks.
Thank you, sir. So now I would also like to thank our speakers for these enlightening presentations. Thank you, Dr. Manish Chande, sir, and Dr. Akhilesh Mathur, sir. Also, highly thankful to Dr. Anuj Maheshwari, sir, and Dr. Amit Gupta, sir, for their constant efforts in making the ACP case files a grand success among the physicians, both in India as well as abroad. Hanji, sir, Dr. Manish, sir.
Thank you, madam.
Thank you, sir. Thank you, sir.
Thank you, everyone. Thank